It is recording. Since the intent here is that there are a small group of us, I'm fine if you all want to go off mute, and you could even just raise your hand like this if you want, or we can go in turn, whatever your pleasure is. First, I guess I'd like to ask the group, what I could do is put up the one slide that shows just the 9 themes all on one page, and then look to you whether or not you'd like to discuss them in turn, or if there's a specific area you want to focus on first to make sure we cover that first. I think from a kind of a thought process, I'm sure you all have comments already, but what we're mostly interested in is, first, what is your initial impressions on the themes? And is there anything in particular that you think is missing, whether it be an overall theme or a sub-theme? And then also from your individual perspective, from where you sit in relation to your membership in the committee as a person with lived experience, as a provider, as an entity that is responsible for services, more than one location that you sit in. Talk to us about how the themes are framed and what you might think would be a way that they could be enhanced from a language perspective. So would you like me to put up the themes or on that one slide, or are we okay just you have them available to you? It's up to you.
I'd rather see your faces. I mean, I have a copy.
That's fine. Yeah, that's my question.
That's my preference.
Yeah. Okay. That's fine with me. And then I guess for the group, by no means do we have to go in order. Do you want to go in the order that they appeared, or does somebody just want to start off and give us their first impressions? Ron, go ahead.
Maybe you could just clarify this for me, because I may be missing it. It seems like there was a pretty large body of crisis response that is occurring, and I can't find how it's being reflected so far. And I guess I would say it's the triggered by 911. So that may not involve BHASO resources. It's what happens when someone doesn't know what to do and they call 911. So is that body of response already reflected in these themes, or is it just too hard to capture it?
Well, I personally would say it is a little harder to capture, but that doesn't mean that we shouldn't try and capture it. I don't think that it's reflected. It is weighted more heavily towards the delivery system that was described and less on the 911 response. So I know that there was specific community forums related to that, but that was only one avenue to receive some, in that case, more qualitative information than quantitative. I would like to get more of both from that perspective for sure. So I'm noting that we probably need to uncover a little more from that lens.
Because I'm thinking in terms of mobile crisis response, I think it could be a subcategory of that kind of response when it involves, say, a navigator or a mental health professional embedded in that response. And fire reflects that, law enforcement reflects that. And then also I would also try to highlight, hospital workers that are there receiving the results of those calls as well.
Okay. Pasha?
I just want to say, I read the report. I'm honestly overwhelmed and confused. And I'm thinking, I'm willing to make a bet not everybody on the CRIS committee knows all the moving parts. I mean, right, already we see a disconnect. Why didn't HCA know this report, and so on and so forth. But since I'm lived experience and just a person of the public, I'm like, how are the people who are watching this that are not on the CRIS committee receiving this information? It is a lot. So I want to make an appeal for there to be a way that this information is distilled down in a way that is simple to understand, so that I think this is the part of the process that turns people off. Things get so complex so fast, and they are, but there has to be a way to make them digestible, even if they're not like down to the nitty gritty. And if people want to get into the details, they can. But I think there has to be a way this has to be presented to the public that is more accessible to for them to understand.
Okay, thank you. Linda?
Um, one of the things that I have brought up in the first meeting, and I still feel like I have to keep bringing up, is that there's a part of the system that's not part of the crisis system, but it handles crises, and that's the substance use disorder programs, especially withdrawal management, but ERs also. And I don't know that they're well accounted for in here. What we've observed in our detox is that the people that we're seeing are increasingly more acutely mentally ill than we ever saw before. Now, either they're not getting to the right door, or the doors are, the places are full, but we're an important part of the system, but I don't suspect that our data is in here.
I would agree that it is not, and I am working in other states on more of the substance use disorder side and less so on the mental health side. Obviously, they're so intertwined, but I agree that, I mean, that's a component that I think needs more attention here as we get into more of the particulars.
Thank you.
Levi.
Yeah, thank you. I just wanted to, Representative Orwell and Jen Stuber both mentioned and Michelle, the National Suicide Prevention Lifeline component, and that 988 will be running through the National Suicide Prevention Lifeline, or Vibrant. I think that needs to be an important piece of the conversation to inform everyone on the call that doesn't work in a call center or is not directly related to that is the the entity that right now will be directing all 988 calls into Washington State. And that only current NSPL centers, which is Crisis Connections, now Frontier Behavioral Health, and then my center, Volunteers of America, are National Suicide Prevention Lifeline centers that will be able to take those calls. It's important to remember too that for the vast majority of individuals that are calling a crisis line, that it will be their intervention, their interaction, their support. The downstream piece is incredibly important, and we play a role in that as well. And I think we definitely need to focus on that as part of 1477. But from a call center perspective, I'm going to advocate for the centers and say that piece is really important because of how much work happens there. And then that for each of the call centers, we're all National Suicide Prevention Lifeline centers, but we also all have contracts with BHASOs and provide regional crisis line service as well. So we do have some kind of institutional knowledge on how we work and integrate that process.
Thank you. I appreciate that. I'll be honest. We at Health Management Associates did not want to be in conflict with, and quite frankly, step on the toes of work that was already well underway before we even started our process. And we're working with Harvard Behavioral Health Institute. And so we've been awaiting the Vibrant report, and I know it's still been in process. We were just offered the most recent draft, I believe it was last Friday, and are anxious to incorporate that information so that we're not, we're all joined together here on the information sources. Quite frankly, honestly, with the timing of getting the materials out to the committee and then not getting that report till Friday, we couldn't put the two together. The intent is to put all that together in the report that goes to the legislature.
Yeah, that's great. And then I think I would just add, Mark, that I know that data from the Lifeline centers and the calls that they take does get reported up to the state, but at DOH, not HCA. So that's also, you know, just
Okay.
a difference there as far as that data.
Thank you.
Yep.
Darcy?
Hi, I just had a couple of questions. In regard to, and I want to tag on to what Ron said about capturing people that go to the emergency departments with crisis that walk in, right? So there's a lot of people in crisis that just walk into emergency departments. I don't know, it doesn't seem like that's captured anywhere. The other population I'm kind of interested in is, not more than half of our population in Washington is not funded by Medicaid or unfunded. They are either have commercial insurance or some other kind of public funding. And I don't see where they're reflected in this. Is there a plan to do that later?
I would certainly like that. I don't know the availability of information from those populations, but when we say from the BHASO's perspective, non-Medicaid would include not just those that are indigent and not on Medicaid, but also commercial and those that do not have a benefit that includes crisis services. So that could include the commercial population. I mean, their purview is everybody that is not on Medicaid as well.
Well, I mean, I understand it in theory, but the reality is that the BHASOs don't pay for a lot of the services that people in the crisis that are funded by other people. The commercial
Right,
pays
from
for.
what I can tell is they don't get
Right.
enough money to pay for it.
Yeah, so I just wonder, it seems like we're still not capturing a lot of the population and their experience in the system and some of the challenges they have in the crisis system.
No, I don't disagree with that. On the ED question, I posed that very early in the data investigation process. We are still working through, at least on the Medicaid side, getting the data. So we don't have it. I thought that would be one of the very first places to look. And to Linda's point, looking at folks that both receive substance use disorder treatment and mental health services, as well to intersect that group as well. We would like to take things down to that more level of granularity, but we don't have the data available yet to do that. We're working on it.
I just want to jump in. Mark, are you recording this? We were supposed
Yes, yes. I was recording from the start. Yep. Okay, Michael.
All right, thanks, Mark. Yeah, I have a bunch of thoughts. I think you guys did a great job with that very complex system of trying to capture data. I mean, as an ASI, I participated in the data. We had an interview with Mark and your team. But even seeing it, it still gives me a reaction. The one thing to some of the conversation just now, I think is important to think about, it's just my opinion, is the crisis system is so big and vast and complex that what is the scope of what we're trying to achieve here? Because this is really related to the 988 system and then the resources that are sort of like an extension thereof. I think to Ron and Darcy's point, like the hospital system is a huge part of the crisis system, and data that's pretty much readily available if you're accessing the right systems, which the 988 system doesn't have access to. So, but I guess I question, like, do we want to go that far in terms of what we're looking at measuring and capturing and creating a picture of? I think it's important because I think a lot of people that are calling 988 do end up at an ED. It'd be great to be able to connect those dots. Right now, our technology doesn't really do that. That's why in terms of follow-up, it's like, well, for the people that successfully get off of a crisis line call and don't access other systems, you don't know what you don't know. And so how do you actually effectively measure that in terms of successes? Because then people don't access the hospital or call 911 or call police. So I think it's important to think about the complexity of, like, again, I think you did a great job with this. I think getting feedback and polishing it and presenting it and to Pasha's point, a succinct way so that the general public from maybe a 5th grade reading level could look at it and say, oh, that's what you're saying. I did have some reactions to some of the numbers, like in mobile crisis teams, it says 3 for King County, yet there's 8 in Spokane. But I want to make sure that we're also measuring apples to apples. And I'm wondering if different regions answer things differently, because King County, we have a lot of teams. We have 3 at any given time. But so I guess going back to that and saying, like, what are we measuring? I think Representative Orwell also, I'm just jumping different points, made a good point to think about what is the intention of looking at crisis line call volume? Because my own experience of working in the crisis call center, like a lot of those calls, especially in King County, we have a large volume of calls, but most of those calls are not coming through the National Lifeline. They're coming from the local crisis line. We actually pay Crisis Connections to be the after-hours support line for all of our enrolled behavioral health clients. So a lot of calls are really the mental health consumer, behavioral consumer, just like looking for support. So maybe it's certainly not a suicide call. There might even be a nature of crisis, but it is a good sense of emotional support and prevention. So I say that because I wonder, like, does that call volume that we're reporting actually inform us about how we want to design a system for 988? I think, again, maybe that's apples and oranges. So maybe having conversations around what are we trying to get at by doing that? And then again, call volume, we don't know what we don't know. So the call volume could be duplicated people. So how many individuals are involved in it versus how many calls? So anyway, a lot of random thoughts, but I think my final thought is, I think for the purpose of this conversation, because like you said, you have these 7 points, like I guess my question for you is, what is helpful to HMA in this conversation for us to discuss? Like, what are you looking for in our kind of feedback and debriefing here?
I'll answer that first, and then I want to give you some follow-up information on some of the other comments you made. The first one is, I guess if you think about the themes from accessibility, use of services, accountability, outcomes, technology, like, from the perspective of those receiving the services, was there a specific theme that you believe was completely omitted, so that we want to make sure that we don't omit it in the final report? You can certainly contemplate and think further beyond today about the nuances of the sub-themes, and if you want to provide specific comment on those, we welcome that. So that's the first thing, is just like, before we start to kind of further delve into the 9 themes that were presented, is there a 10th one? Is there, we fully appreciate that there's cross-cutting things that are going to cross the themes we did present, but is there something else that's just glaringly missing? That's what I'd like to know. So thus far, what I've heard is that so far, well, no one's specifically said yes or no, but the themes are resonating, but kind of the underpinnings of it, whether it be information from 911 when it comes to utilization and delivery of the services, and those that we need to put a little more meat on the bones, if you will, around some of the existing themes that were presented, as opposed to a brand new theme. But we're certainly open to all those things. It's the committee and the steering committee's report. We're just providing the technical support around that. But the one thing I did want to comment back to you on, Michael, because we did have this conversation with you and others, that I worry that from the basic level, as Vipashis was saying too, like, is everybody even operating from the same position about what they know what the services are? Like, what do they mean? When somebody asks, what is a crisis stabilization unit? What does that mean? So I worry that the data that we presented today was the only data we had available to present, but I am suspicious that there could be different interpretations based on definitions even there. So I worry putting all these things side by side without understanding more about how everyone's interpreting, and anything we can do to help. it's such a service that is so individualized, but at some point when we're looking at kind of outcomes like, is the system working or not? We have to have some working definitions that everybody needs to abide by, at least on some things. So I'd like to help steer that where it's appropriate. So no one else has a hand up, but I guess, can I come back to, does anybody, oh, Linda does. But I also want to make sure, does anybody feel like there's anything glaringly missing? But first, I'll let Linda speak.
Oh, I just have been following the data during COVID about all the crises. And of course, we're in the middle of opioid crises, as well as a lot of suicide going on among people in recovery too. And what I don't see when I look at the data is I see a lot of people calling with alcohol drug issues, but I don't see many referrals resulting from that. So I don't know what happens when a person identifies that they may be alcoholic or drug addicted, or maybe they don't, and maybe they're not getting quite the right response. And I don't know how you get at that, but it seems like the data seems very pointed to a mental health referral, but the data on crises is much more broad. So I just don't know the extent to which the state has the capacity to really look at, do they target their responses in crisis to the problem?
So let me give one personal feedback on projects that I'm working on in other states. And they actually are more centered on SUD than mental health, behavioral health. We like to look at, we call it like transitions of care. Like say there was an acute event, whether it be a mobile crisis team went out or an inpatient hospitalization for behavioral health or substance use disorder. And then, what happened immediately before, say the 8 to 12 weeks before, and then the 8 to 12 weeks after? Like what precipitated that acute event to begin with?
Mm-hmm.
And then what happened? So right now, the only reporting is on, at least to HCA, like the immediate, like you saw that one slide, they went outpatient, they went voluntary inpatient, they were, involuntarily admitted. But then what happened after that?
Mm-hmm.
That's what I'm interested to know about, to kind of really understand the more continuum. And could there be things that could have been done? I mean, I know Michael has examples of the preventative side that helps to prevent some of those acute episodes. I mean, it would seem like that's where steering the ship is, where everyone wants to go, right? It's not that we don't need to have all the services available, but how can we steer the ship more to prevent them to begin with? Go ahead, Michael.
Yeah, I mean, just want to react, just knowing where Linda's coming from Evergreen, it just makes me have to observe that, we have a long way to go in terms of how we respond to crises for behavioral health in general. We've only just recently achieved integration for mental health and SUD services. So DCRs can now detain for substance use disorders, but that's still new. And when someone's getting outpatient treatment for substance use disorders, the Medicaid rate doesn't include crisis services. Mental health, it does. And so that's been from an outpatient provider point of view in King County, that's always been the push and pull between, what happens after hours for the person getting only substance use treatments. If they're co-occurring, they could default to the crisis system. But I would say we really don't have a crisis system for substance use disorder. So that's another thing to consider while we're looking at this.
Yeah, and if I can just tag along, because we have lost many of our detox facilities. And then for reasons I don't understand, the state has focused on putting in secure detoxes. You don't have to lock most of these folks. And so I don't know why we're focused on creating secure detoxes and not supporting the detoxes that are out there where most people will stay if they're treated well.
Mm-hmm. Thank you. Darcy?
This conversation does bring up a question for me when you're talking about where there might be gaps in the assessment report. That when you're describing the different crisis response services that are available. There is, on one of the slides, I don't remember which one it was, it talks about the involuntary beds and about single bed certs and those sort of crisis response services, but there's no category about that. And I agree with Linda as well, is that there's not a category about what happens if, you know, a diversion to a community isn't appropriate and they really do need some crisis inpatient. When we have big gaps in that across our state, both in, you know, in substance abuse, in mental health, and in, you know, dual programs. So which impacts the entire crisis response. So that might be a, you know, a missing component of the assessment.
Okay, thank you. Anything else immediately comes to mind?
I have a question. So this is just
Sure.
reflecting on what Michael said, and actually I worked with Michael, so which was an honor. But and the fact that you know, Levi, you also brought up that this is through the National Suicide Prevention line, basically. And I agree with Michael. Most of the calls I take on the crisis line don't come through the National Suicide Prevention line. I'm sure Volunteers of America also maybe has a similar experience. And when we do our work, we say the client defines the crisis, but what exactly are we focusing on right now? We're focusing, like, even the word crisis, what are we defining? Is it that someone has to be suicidal, near death, imminent death due to substance use? Like, I'm not sure. Just listening to you all talk, like, okay, so then if what is the 988 system, as Michael said, trying to address? And if it's, I'm not sure we even have now a clear definition. I have a clear understanding of what it is trying to address. And then what happens if to the populations right outside the periphery of what we're trying to address? And yes, on the crisis line, we say if someone calls stress because their cat climbed up the tree and can't be down, we meet them where they're at. That is their crisis in the moment. Also talking to people, I'm suicidal, I have a gun right here. There's a big space in that. And so now I'm even more confused about what it is we're
I'm
trying
with you. So my first question when I joined the project is, how are we defining crisis from the perspective of scope and duration? In other words, is it limited to whatever the reason for the person calling into a crisis line, whether it be 911 or the BHASO line or the national line? But as you've all said, and many of our stakeholders have said, we get a wide variety of calls to those lines that even those in the profession would not necessarily characterize as crisis. I mean, it's such a wide range. So, and there should be no wrong door for people who can still obviously call. But then the question is, well, how do you assist those that are not necessarily in immediate crisis, but can use that line as a resource for something else? So the legislation, as we have interpreted and confirmed, the ask of this, well, it's the steering committee is delivering the report. So we're just providing the technical assistance towards it, but in helping to support that, the first question really is, what are resources needed to stand up the 988 lines come July 1st, 2022? So that's more the infrastructure of the lines themselves and staffing. But then it also goes beyond that and says, and then the delivery of services as an outcome, like where do the folks on the crisis line then direct people to? So we have been taking a broader stroke, approach to both the utilization and the funding and all of those things, because then there's another section that specifically states, first of all, will the telephone line actually cover all this, which my personal suspicion is no way. But also, in the event that it doesn't, what would be recommendations about where to prioritize where the need is greatest? So it's back to not only what is crisis, but then what are the services that we're defining for that prioritization recommendation or everything else? So I would like maybe the committee to kind of contemplate that as well, personally, so that we can be the most supportive of answering the questions, either from the legislation as required or any other questions that might be coming up along the way.
Yeah, I think this gets to a good point in the assessment. Variation was a theme, right, in almost all the categories. And to get a real understanding of how realistic it is, I mean, how much, I should say this differently, how much variation is, should we expect, right? Because we're not going to be able to standardize everything across the entire state in the different communities, and they won't want that. And so how do we balance out standardization with the need to be, sensitive to the needs of the local communities?
I
Right,
find
and
that
that's
in a lot of projects that I provide support for is that there's the fine line between those things that everyone can agree we probably should have some standardization to, but then honoring whether it be local or individual community-based, population-based solutions that are working well within that group, that we should let them kind of drive the approach for those things. So how do we marry the best of both worlds, I guess? I don't think it's certainly not one-sided one way or the other, probably.
right. That's why I think the longer I do this ASO work and I connect with other partners across the state, it's more and more apparent to me that, like Lapash used the phrase, meeting people where they're at. Well, meeting somebody where they're at in Seattle is different than in Spokane rural areas or other. I mean, I could name so many different parts of the state. And so to Darcy's point, how much variation do we tolerate? Which I think we need to tolerate some, because you can't do the same thing all over the state. So again, I think the crisis system is complex, and I think the task before us is even that much more complex, because I mean, I would hate to think that we're going to try and just standardize everything and say, here's what happens for every 90-day call.
Right.
Because we do have to, we have equity and social justice principles. We have sensitivity of where people are coming from and where they're at. And if we're truly going to meet them where they're at, we have to tailor our response to meet their needs, not make them fit into, our own system.
Oh, I wholeheartedly agree with that. I mean, certainly the delivery system probably will take some unique perspectives throughout the state based upon the population being served or the situation geographically around them. I guess, I was one of the authors of one of the sub-themes about, like, I was just worried that I would call the collection of information, there's an awful lot of data, but not a lot of information. And what I mean by that is that what information is most useful from an outcomes perspective. To say that there's 20,000 calls or 22,000 calls, I don't know what that means. What do I do with that piece of information? I want to know more about, well, what happened to those people after the call occurred, and those types of things. And also the something we had about, there's very little on the individuals and families' perspectives on the outcome side as well. So I'm a data person at heart, so I do like having data from a collection standpoint to have some key measures, but we need the kind of the more personal outcome experience information as well from those that were receiving the service. I was also taken back by the comment about, that you mentioned about some folks have more trauma leaving the system than entering. So, like, what's going on how can we make the outcomes more, improve the outcomes for the individuals who are at the heart of the whole system to begin with? I mean, everything around it is just a mechanism upon which we're serving these individuals. So how can that delivery system, I mean, the onus should be on the individual and helping them improve their lives. So
Yeah, I forget what setting it was at, but I was in a meeting with Senator Dingra, and someone asked her, as we're doing this work, looking at the crisis system, what does success look like? And her response was she wants to be able to see, like in 3 and 5 years from now, this the success looks like less people being ITA'd, less people going to the hospitals, less people calling 911. And I would agree with that. I think that makes sense. I think the challenge is, how do you measure that? Because if it is from a data point of view, how do you connect the dots of, well, here's all these people calling in 2021, and in 2026, we now see less ITAs, but is that because of the same people? Because in 5 years, we're gonna have different people too.
that's
So,
right.
and a crisis line in 988 is open to everyone and anyone. So I think I agree with you, Mark. I think that data is so important and it tells us the story. I just think in a crisis system, especially when people call anonymously, how do you capture that and how do you tell that story? I think that's really hard.
Mhm. Yeah, absolutely. So you don't see, but I'm getting the 5-minute warning sign. I don't know if you are too, but so I guess I'll let any closing initial impressions, we'll call them, but I want to make sure, since I'm responsible for reporting out for our team, here's some of the themes or comments that I heard back from you. One, I guess, was Vipasha kicked it off with that just overall confusion on the information and finding ways to make it easier for the public to understand and synthesize. Second was Ron keyed us off with that. It appears that we're missing a body of information on responses from 911 and those that are doing mobile crisis from other delivery service delivery models other than the BHASOs. Linda and others mentioned that we really need to be thinking about crisis as it pertains to SUD and its continuum, as well as behavioral health. Darcy mentioned that we certainly shouldn't lose sight of ED use, and particularly for behavioral health, I agree. And also wherever we can fit in other clients from other insurers like commercial. Let's see. We also, I think a few of you mentioned this, and I mentioned too, like the definitions of the services themselves need to be more clarified, not only for this report, for ongoing subcommittee work in 2022. You know, the concept that we saw an overarching theme that things are very varied in Washington today, and that can certainly work well for some things and maybe not so much for others. So where's that fine line, and where is it appropriate and maybe not as appropriate? And then, you know, any themes around centering around meeting people where they are in the delivery model should be given closer attention. Is there anything else you think? I mean, this is the beginning. There's more opportunities after this one, but for today's purposes, anything else you want to make sure I mention, or if you all have any other thoughts for me to add to that list?
Good list.
Yeah, and as Jamie said, we're recording these. Someone's going to kind of collate and synthesize, and we were directed as we report back. If some other group has already mentioned one of mine, I'm not going to keep repeating it. So we're going to kind of build off each other's, but then we're going to put them all together. And then in addition to that, take the written comments from committee members that we may receive until the 30th, and then further synthesize those lists as well before delivering any report. So I guess, think of it as, although they're going to come in rapid succession, there's multiple avenues to synthesize these refinement of the themes. So I just got a 1-minute warning, so I guess we made good time. I appreciate everybody contributing
Yes,
today.
yeah, thank you, Mark.
Thank you.
Certainly, absolutely.
Thank you.
Well, we're leaving.